Cool. Thanks for inviting us to speak. My name is Graham Bailey. I'm a former fellow at ultrasound at Highland. And right now I'm working in a community trauma center in Eugene, Oregon. And one of my amazing partners, Tanya Bucherka, is here with us today. And I asked her to come because she's doing some really remarkable work in Ukraine, teaching point of care ultrasound. And I just thought what she was doing was really remarkable. And I thought this community might be a great place to kind of discuss some of what she's doing and maybe create some opportunities for partnership. Maybe Tanya, you can tell us a little bit about your background and kind of why you're doing what you're doing in Ukraine.
Yeah, thanks, Graham. I'm very honored to be here and speak with you guys. It's been a very rewarding journey into global health working in Ukraine teaching point of care ultrasound. So I'm originally from Rochester, New York. Both sets of grandparents came from Ukraine. I spoke Ukrainian before I spoke English, spent many childhood summers in Ukraine. So as soon as the war broke out, I knew I had to do something. I speak Ukrainian. I'm an ER doctor. I was like, okay, I need to get on the ground. I found this NGO called Med Global. If you're not familiar with them, they're a Chicago-based NGO that goes into hot zones. They're in Gaza right now. They're in Syria. They're in Bangladesh. They're in Colombia. So I head up their point of care ultrasound team in Ukraine. And so I've been on 7 mission trips with them with more to come this fall.
That's just super amazing. I think like we all are really in awe of the people that are going there and doing work on the ground. But I'm sure it's also seems kind of dangerous at times. Can you tell me like what type of format are you teaching ultrasound in? Are you
Yeah.
in combat zones doing ultrasound? Are you teaching the teachers? Kind of how have you found it to be most effective?
So it depends on every trip. It's definitely evolved since we started. So Med Global was one of the first NGOs on the ground in April or March of 2022. I went in April when the conflict started, February 22nd. Initially, we stayed very far west, like Lviv. But now we're heading more east. We don't just teach, we also incorporate a point of care ultrasound teaching with the surgeons who are also doing a surgical course on traumatic amputations and thoracotomies. Just a side note, like gun violence was not a thing in Ukraine prior to the war. So fasts were not part of their protocols. Using point of care ultrasounds was not part of their protocols. So we've kind of tailored it since the beginning of the war. So initially we would go in and do a 2-day course teaching fast, e-fast, a quick cardiac, a quick lung exam. And we were teaching doctors that were volunteering to go to the front lines, which in my mind is just crazy. So my first couple trips, we were training ENTs who had never touched an ultrasound, pediatricians, orthopods, just family doctors, anybody that was willing to go to the front, we were willing to train. And evacuations take place on the front in 2 minutes in an unmarked car, and they have, 2 minutes to do a quick POCUS to determine which stabilization point they can go to because they're ranged 1 through 4. 4 is all the way like the tertiary center, where 1 is the closest um, hospital that can do an intervention. So it started training those people, and that has kind of grown. People have gone to the front and are teaching other friends what they've learned from our courses. They're saving videos, they're asking questions, they're referring more people to our courses, which has been great. So we've done that for about 5 trips. Most recently, I was just there in June, and we taught an advanced course to students that we had already taught. So that was really great. We did some nerve blocks. We did like pang blocks. We did like serratus blocks. We did transabdominal blocks, which was really awesome. But each time it's in a different city. I mean, obviously, so Ukraine is about the size of Texas. All the way in the east is where the fighting is. We've stayed mostly west, but now we're mostly centered in Kyiv, the capital, which is right in the middle, because it's easy for participants to get there. To say it's safer than being on the front. But it's not, I mean, you're in a war-torn country. Like, it's not like there's active fighting where we're doing the training, but one of the hospitals that I did the training in, the children's cancer hospital was bombed shortly after we were there. I mean, we take all the necessary precautions. When an air raid siren goes off, we do go to the bomb shelter, and we actually can teach down in the bomb shelter. It makes it, these students are just hungry and want to learn as much as they possibly can.
It's pretty amazing. When you, it just seems like an insurmountable task to go and teach point of care ultrasound to a country that maybe it was underutilized prior to the war. When you went with those initial classes, did you say like, these are the things that we think will be useful, or did they come to you and said, teach us, these specific kind of, features of point of care ultrasound?
Yeah, so we initially, like, we went in with a plan. Noreen Ahmed, she's the director of like global health at UPenn, and so it was me and her initially. So we were doing, we came in with a rough plan and obviously addended it to what they were seeing on the front and what people wanted to learn. I mentioned this to you, Graham, with further trips, we started with EFAST and FAST and cardiac and seeing how people responded to that and what questions they had. And then it turned into, wait a second, can you use this for foreign bodies? Because soldiers had pieces of shrapnel in them, and the way that they were extracting them was using a magnet on the patient's arm or leg, wherever they thought this shrapnel was. And whenever the patient like shouted, that's where they anesthetized and cut in and searched for whatever object was in there. And to me, this was like a foreign thing because I'm so used to GSWs. I said, all right, well, that's like sterile. You don't have to chase after it. And they were like, no, you don't understand. We don't want a piece of the enemy within us. And I was like, wow, that makes total sense. And it was something so simple that we could teach, such as looking for a foreign body, that really um, changes their practice. And same with DVT ultrasounds. Each trip, it's just evolving and we're realizing what they want more of. A lot of these evacuation trains from the front take like 3 to 5 days to get to the west. There's a doctor or two per every train of these ICU patients that are pretty much just like stacked cots on cots in all of the trains who aren't getting prophylaxis for DVTs. They get to a hospital, there's one sonographer on who can't possibly image everybody for DVTs. So being able to teach that skill and getting people the treatment they need quickly has definitely made an impact. And it's just stuff that we do here so routinely that I would never think would make such a big deal there. Because military hospitals, kind of like, VA hospitals here, like they don't have ultrasound overnight. So they're like, oh, we would work to transfer a patient for a DVT ultrasound in the following days. But here we are handing them these tools to use on the spot.
I find that like super interesting how your teaching has kind of adapted to the culture and kind of their needs in combat zones. Because I think could easily come in with this, predetermined set of skills that we want them to learn, but that might not be the most appropriate thing. What obstacles do you feel like there have been, or that you guys have had to overcome in teaching? You mentioned that you were teaching pediatricians and ENT docs. You probably didn't have any familiarity with it. Do you? Are they harder to teach doctors who don't have any familiar with it? Are you planning on teaching people outside of just physicians, or kind of how do you see the program expanding?
Yeah, so we've definitely focused on physicians thus far. It is hard because you have different skill levels in each course, but I think we kind of try to group the same people together um, to teach them that way. And now with like having an advanced course, we can separate those people who know what they want to focus on more. Initially, we were there to just teach like as many people as we could, just life-saving skills. I mean, on the side, we were teaching like POCUS from like 9 to 5. Then at night, we were like trying to teach locals like stop the bleed and tourniquet use. Because the initial days, you're just trying to do anything and everything that you can to help the people. And now we can see what they're using more of and kind of guide our teaching from there. I'm sorry, you asked what was the end part of that question? Oh, where do I see this going?
Yeah.
Yeah, so I see us definitely doing more advanced courses. I would also love, if anybody wants to hear more about my experiences and would love to volunteer, that would be awesome. Working on online lectures that we could have these set nerve block lectures that we can disperse to people, or to do lectures just like this. Obviously the time difference is a little hard, but doctors are willing to stay up any time of day to do this. Um, like I did a virtual teaching in Ukraine. I was in Kyiv. People were really close to the front, and their hospital had no running water. They had no electricity, but they like all sat around one iPhone that had internet connection. We're like, can you just show us how you use ultrasound on the lung? And there's like, 50 doctors around there like looking, and we're just like, wow, this really is making an impact.
I think that's like a great way for people to be involved if they can't pull themselves away and go to Ukraine, which obviously would be fantastic. Do you feel like online lectures like would translate well? How do we overcome like a language barrier and kind of translating the knowledge base that we have to the team over there?
Yeah, so on all of my trips, I'm the only Ukrainian speaking person. So all the trainers we take are English speaking. We have wonderful translators that are med students, usually on our trips that do the translating. And the same would go with lectures. If anybody was willing to record a lecture, then we would have our Ukrainian translators kind of go over it in Ukrainian or provide subtitles. And I just wanted to say a shout out to Butterfly. Like Butterfly has been super awesome. Their global health department. They have been working with us. Like soldiers will contact me saying their cord broke or this happened, and Butterfly has been fantastic replacing those. They're offering the online, like all the videos, the educational, the cloud, everything is free right now for those in Ukraine, during the war, which is just absolutely fantastic.
I think that not that we're sponsored by Butterfly or have any affiliation, but I think it's really cool to hear that they're supporting you. And I think it also provides a really interesting format to perhaps consult, remotely. Or I thought one of the things that you mentioned to me while we were kind of going over this talk that was interesting was that you wanted to create a QI kind of QA program for ultrasound images over there to kind of improve on their skills. And I thought that that could really be a really unique format to do that.
Yeah, absolutely. And that's definitely like one of the hardships is just like all of you, I work full time as an EM physician. So when I take these 2 weeks off, I'm like, okay, this is what I need to do to improve this program. I'm going to set this up as soon as I get home. And then you get into the, um, you know, daily life. So yeah, I think that that would be super helpful, especially because we give out butterfly ultrasounds with our organization, and part of the contract that they sign is that they are going to send us images and we are going to try to review them, but then we just haven't formed a group to be able to do that.
Yeah, that would be cool to be able to form like a work group where we could share images
Yeah,
and
totally.
I know that that's new here, but that's definitely been done in other places. And one thing when before we kind of came online, Dan had mentioned that I thought was really interesting was that you might be able to identify kind of superstars, people that are getting really good at certain skills, and then make those people kind of teachers of other groups within the field. One question that you talked a little bit about that someone brought up in the chat is kind of what specific regional anesthesia needs are you finding that they need there, right? And kind of what blocks are kind of the most useful to the docs there?
So honestly, they are willing to learn any block, and any block would be important to them. Like before I went this last time in June, they were asking for specific retrobulbar blocks. And I was like, I have never heard of that. I don't know how to do that. They're literally looking for anything. Peripheral nerve blocks, which was really great to show them what a nerve looks like on ultrasound for those not familiar with it. I mean, as many of you know, Ukraine is not the highest in healthcare. So they've got the ginormous ultrasound machines. They're not used to the portable devices. So we kind of blew their minds the first time that we went there. So just even showing them what a nerve looks like on ultrasound was amazing. And they're just doing so many amputations in the field that, and truly any nerve block helps them. We had Melissa Hazlitt went with me on my last trip, and she's ultrasound fellowship trained, and we did like a meat model for ping blocks, which was really, really cool. They're interested in learning anything that anyone has to offer, truly. And
Do you
our
find
end,
that like I'm sorry.
sorry, go ahead.
I was gonna say, do you find, one of the things that I feel like we kind of all know as ultrasound fellows or people doing regional anesthesia is that once you learn to kind of localize a needle tip kind of on ultrasound, you can translate that skills all over. Do you find that the providers there kind of are need that initial kind of shove, and then once they do that, they can kind of learn those other blocks really quickly?
So everything that they do is without ultrasound. So they're like very comfortable with like their needle control and doing blocks, but I think it's just understanding what it looks like under ultrasound to be able to expand the locations of doing these blocks.
I'm sure that comes really quickly then if they already have
Yeah, it
those kind of
totally
tactile
does.
skills. Uh-huh.
It absolutely
When
does.
because you're not only teaching those technical skills, but you're also kind of building the infrastructure to support the ultrasound program. Are you when someone gets a block, is there any record of that, or how is that communicated to the rest of the field or the rest of the team, if they're going to surgery and perhaps they're getting more anesthesia there, or is there a protocol for that type of thing?
Yeah, so that actually, I can't answer too much to that, but I know it depends on like the location that it's going on. And obviously, if it's a hospital, they like mark that leg with the time and pass that on to the next doctor. But in the field, everything's just happening so quickly that if somebody does a block and then they do an amputation, it's just like done there on the spot.
I feel like sometimes we're hyper vigilant, maybe over vigilant for complications about regional anesthesia. It'll be interesting to see kind of what comes out of the combat zones and to see, if there's issues with infection and, adverse medication reactions and that type of thing. Because it sounds like sometimes the blocks are a little bit kind of down and dirty and you're just kind of getting the job done in the combat zone.
Absolutely. And there's a lot of issues with post-operative infections that are going on in Ukraine and just there's a lot going on, and I think we'll have a lot more soon. It's crazy what they're dealing with and how they're going to be the professionals on wartime medicine because we haven't experienced this. Also, something I just wanted to mention is some of the doctors I was just training in June, um, a traumatologist came to the training, and she is one of the first Ukrainian doctors initiated into the American College of Surgeons, and she's working on a new protocol. It's the U fast, the Ukraine fast, where they're measuring people's colon diameters with injuries and checking like certain hours post-injury to see if they have colon damage. And they're also trying to use ultrasound looking at different retroperitoneal hematomas. So that's like just some research that they're doing on their own there, which is neat.
Yeah, super innovative. It's kind of one of those things where they're just kind of adapting their skills to their needs.
And they have
Um,
to. And when I say like these people are hungry for knowledge and just so appreciative for anything we have to offer, I mean, the resilience of the Ukrainian people is something that you just like have to see firsthand.
with each of these courses that you're doing, how many people are you teaching each class?
I'm like 20 to 30. And what happens is we'll run the course, for 2 days and we're there to run it two more times. And then a friend tells a friend who tells another friend from another hospital. And then sometimes they become a little overpopulated. But how do you cut off people from this knowledge when it could be life-saving knowledge when these hospitals are getting wounded soldiers on a daily basis? The courses definitely grow. Like I was walking in a grocery store in KU and somebody heard me speaking English and they're like, "Oh, are you one of those people teaching that course? Like, can I bring my friends tomorrow?" And I'm like, "Sure." So, they end up just exploding with people.
That's super cool. And I think like if US history is any clue, that every wartime kind of creates a lot of medical innovation, and perhaps what you're teaching now is going to carry through after the wartime. Once Ukraine has finally won the war, that they'll be able to take all of this ultrasound knowledge and you'll be creating this regional anesthesia, just like nuclear bomb that's going to take over and everyone's going to you know have all these skills.
Yeah, I hope so. And that's kind of we're moving forward with Med Global to try to introduce point of care ultrasound into medical schools there as well.
Super cool. I think that's most of the questions I had for me, but from my personal stash here. But I don't know if anyone else in the group has any other questions that came up in your talk. Probably got a couple more minutes before Dan cuts us off.
Yeah, I think thinking of it from their vantage point, and I don't know the vantage point. I came in a little late. I apologize at another meeting. But simplifying the process of their blocks, if it's in the field, like somehow they can do this. Like slap a sticker on it, stick something, tape on it, just like something that's so simple that it reduces the barriers for them. And I don't know what those are because you guys are in the field and know the answer. So if they have like a bag, a needle, a pre-filled syringe of 10 cc's of bupivacaine, whatever, and everybody gets a 10 cc block, it's better than getting no blocks, right? And they get injured, you block them, you put a sticker on, and you shove them away. And it could be a really useful kind of exercise in a user-based design product for in-field blocks, because I think there's probably a real need for it. And I think the more we worry about infection, I mean, I really don't care about infection because we know the data from us that the infection rates are super low. The rates of last are going to be super low. PNI, do I really care about it? Not really. So I think it'd be really great if we just demonstrated that you have something that could work, because the limitation is if you have an anesthesiologist out there, they're going to want a monitor, an IV, a cart, their loops, etc. Right? What you really want is a simple, do it in the field, reduce pain by whatever, and get them out, right? So I think that you could probably, if you could figure that out, it would probably be very externally generalizable to a lot of different places and a lot of wartime stuff.
Arun just kind of brought up something that raised a couple other questions for me. Are you running into limitations with what local anesthetics are available? Like, what do you find is most used? And are you getting any feedback from patients about their satisfaction with nerve blocks?
They're using anything and everything, stuff that gets donated to Ukraine, they're just using it. We brought up like the toxic lidocaine chart, and they were like, what's intralipid? What
Yeah, I
are you
wouldn't worry
talking
about
about?
that. I would literally pre-fill the syringes with 20 cc's of bupivacaine. I don't think anybody who's in Ukraine that's fighting is under 140 pounds. I would be very surprised. And I would 20 of lidocaine or 20 bupivacaine and just have it pre-filled with a needle attached to it, literally ready to go, right?
Yeah, so I mean that's like a great idea, but unfortunately that's like just not how stuff is actually distributed. They're just, given a bag of meds and they're like, this is what you have to work with for the next 2 weeks. I wish, in the hospitals that would be a great situation. And that's a great suggestion that I will definitely put in our training.
But that's what I mean. I mean, I can't give you those suggestions because you're the one in the field, right? Everybody wants to sit in their, at their fancy quaternary care center and tell you how to run care in Ukraine. And you're the only one that's going to figure out how to get around those loops. And so you'd be like, oh, I have an idea. I think figuring out that idea in that situation will allow this idea to be generalized in other situations. And you could see yourself going to the Gates Foundation and to other, the US military being like, hey, we have a way that we can, I don't know, maybe they've done it, right? So, and
Yeah.
there's a huge anesthesiology group, a famous anesthesiologist that started all this stuff in US. He wrote a book on Buckenheimer, I think is his name. I had the book years ago. But I think that there's some really interesting ideas that you could even just test. And I think it would really have a big consequence because you could scale that up.
Yeah, I love that. Thank you for that suggestion. I would love to chat more offline if you have time.
Yeah, you can always email me. I'll put my email in here.
I think my colleague, one of my global colleagues had reached out to you as well.
Okay, yeah, email me and I'm happy to give you
Cool.
ideas. Again, you're the one who's going to think of the ideas. I'm just going to try to, like push you to be like, that doesn't work here. Great. Then
Yeah.
does this work? No, doesn't work. And that's the way I mean, this is the problem that I had with global health when I was doing it years ago. I'd go to other countries and tell them what to do, and they'd be like, we don't do it that way. I think you
Right.
have to be on the ground and you're the only person that knows it. But I think I mean, unless we never have wars again, right? I think that what you're doing right now could really translate to Gaza, to everywhere else, right? And so I think there's a real utility in figuring out a handheld probe, a needle, and some anesthetic be deployed in areas where you can't take a cart and you can't take an anesthesiologist.
Right.
Let's say you kind of came up with like these 4 blocks that we're going to make universal across Ukraine. They're going to be really useful. You're going to have a little card or a reference, electronically that someone could look at to see how much anesthetic, if it's if they have lidocaine, if they have bupivacaine, if they have something different that they have access to, how much they're going to use for those blocks. Like, what would be a good way that you feel like would be well utilized in Ukraine for that knowledge?
I personally think that's like Graham, like what you just said is like a great idea, because when I'm like there on the spot and they're like asking for these crazy blocks we've never heard of, everybody's like scrambling to like Google and like, how do we teach this? So we don't really have like a universal, like, these are the blocks we're going to teach and this is what we need. So that is something that I would love to develop, is like, this is the, like, here's a presentation for everybody. These are the 4 blocks. These are the steps to do them. Here's like a card printed out for you for reminders.
Yeah, because I mean, 5 blocks, you could block almost the entire body, you know. And I think if you just like really simplified it and like had protocols that even like the people that you aren't teaching, but the people that they're teaching have access to, then it makes it, you know, really translatable. And you could base that off of whatever the local needs are.
Yeah,
And
absolutely.
I think with handhelds, you really have a way of complete, because again, the book that Dan sent out, the one I read a decade ago, super smart, but they're looking at it from the angle of the anesthesiologist. You're looking at the angle from the ER physician, and you're looking at the angle from even more lack of resource, because they're going to tell you to do this block this way in this volume. I mean, you cut that out, everybody gets 10 cc's, right? Like, I mean, it sounds silly, and I know that you're like, that's nuts, that's not enough, but it's better than nothing. So I think that if you think of it in a totally your own manner, I think you could come up with something that's really fascinating. And also, again, like I said, used again and again and again in different environments.
Yeah, I love that.
I think most importantly, I'm just really inspired because I get burnout sometimes with the grind of the emergency department, and you're always so happy and positive on shift. And I feel like that's not separate from your work in Ukraine, that this work like really inspires you and makes you a better physician here at home. And I just wanted to say thank you for that. And it's not unnoticed.
Thanks, Graham. I really appreciate that. I mean, it definitely is hard to come back from Ukraine where people are like, oh yeah, I lost my father, my son, my brother, and now I'm wounded with you know, I've got this problem. And then you get to work and it's like, I stubbed my toe and I waited outside for 6 hours. So thank you, Graham. I really appreciate that.
Yeah, of course.
And I really appreciate you asking me to do this talk. And if anybody, you know, is interested in volunteering, please, I'll put my email in the chat. I would love to chat with you about it.
Cool. Thanks for putting this together, you guys, and having Tanya on.
Thanks, everyone.
Yeah, this was perfect. Thank you very much for your service, and thank you very much for joining us. All right, everybody, if you have further questions, feel free to reply to the email. It's going to come out in a little bit with the summary and her contact information. Otherwise, everyone, have a great day. Thank you.
Thank you.
Good work.